All right, so I'm gonna do a little quick tidbit on chest tubes. This is a really confusing topic, so I just feel like the more that you can hear me talk about it, maybe explain it in different ways, the better you're gonna be. So the purpose of chest tubes really is to remove fluid or air and prevent air or fluid from re-entering. Keep in mind that's the purpose of the water seal in the chest tubes, as well as reestablish negative pressure to promote lung expansion. So within the chest wall, this diagram over here is showing you that there's negative pressure in the pleural space. So over here, it says within the lungs is 760 intrapulmonary pressure. Intrapleural pressure is 756. That's 4 negative, so 4 less. That's what we mean by negative pressure. So it's that pressure in that pleural space which helps us to promote inhalation. When the diaphragm contracts, flattens, pulls down, it pulls on this pleural membrane here. That negative pressure pulls on the other pleural membrane, making space within the lungs, and air rushes in, all related to pressures. So think back to anatomy and physiology. Go look at that again. It might help you to better understand why chest tubes, why do lungs collapse when there's air in the pleural space. That might help you. Go review that. Different types of chest tubes. So there's really 3 different types of chest tubes. There's a traditional water seal that has it's a wet suction, and it has a water seal. So it truly has 3 chambers over here. The first one is the suction control chamber, and an A is listed on this picture here. There would be water in that. You would dump in water up to the predetermined mark, usually 20 milligrams of mercury. Then you attach your suction tubing up here to 2 suction. You turn your suction on to like medium suction, and the amount of water in the suction control chamber controls the amount of suction to the patient. So when there's suction on, you're always going to have continuous bubbling in this suction control chamber. In chamber B, that's your water seal. So again, you take sterile water that's provided with the kit, you dump it into the line that's down here, and these do need to be refreshed. So if you have a patient who is has a chest tube for many days, there might be some evaporation that occurs. So you need to be checking the levels of water on each of these chambers as well to make sure that there's adequate amounts of water. The water seal chamber is what allows air to escape from the patient's chest through their chest tube out to the exterior of this collection chamber without allowing water or air to go back into the patient's chest. So the water seal is very, very important. When you first put a chest tube into a patient and hook them up to this, you're going to see continuous bubbling in this chamber for just a minute or 2 as air escapes from the patient's chest on a continuous basis. Beyond that, there should only be intermittent bubbling in this water seal chamber, because that bubbling tells you when air is escaping from the chest. If there's continuous bubbling here, that means you have an air leak and you need to troubleshoot. Okay? Then the collection chamber is just that. It collects the fluid that's being drained from the patient's chest. On the next page, I'm going to show you the other 2 types. So on the right is the one that I have in class, and the only difference here is there's still a water seal, so there's still water in chamber B down to C, and that is exactly the same as the first one I just talked with you about, and there's still a collection chamber over here. What is different is this A part here. This is a dry suction. You see how it even says it up here, dry suction chest drain under OASIS. The provider orders you to how much suction you're going to provide. You're going to dial it on the side to the desired amount of suction, and then you still hook the suction tubing up to the top where it indicates you to do so, and you still turn the suction on the wall. So this is attached to your patient and their chest tube and attached to suction on the wall. So this is the smallest little chest tube. Oftentimes it is for patients who are at home, you can see it doesn't really hold very much, right? It only has a 500 milliliter capacity. So it would be most common for patients who didn't have a lot of drainage. You can put suction to this, it says, but it also can be to gravity. And there's no water. So it's dry seal and dry suction. Okay, so there's no water seal here. This just has a dry seal. It's just a one-way valve that allows air to escape, but air to not go back in. So how do chest tubes work? So here's like an open diagram of a chest tube. So over here, it's showing you from the patient. So when the air and the fluid from the patient is being sucked into the chest drainage unit, all of the fluid is going to go down into the fluid collection chambers one at a time. So the first one's going to fill. When that one fills, it's going to spill over into the second one. Once this whole thing is full, you have to change the chest drainage unit and just put another one on. The air is escaping across the top here. It goes down and goes through the water seal. So you can see here, there's this water seal allows air to escape through it out to the exterior to the wall suction unit, but would not allow, if you disconnected the wall suction unit, it would not allow air to move back this way, right? The air is only being pulled through the water seal because of the suction. If there was no suction here, the air would not be being pulled through the water seal. So again, remember, intermittent bubbling in the water seal chamber. Continuous bubbling in this chamber indicates that someplace down the system here, you have an air leak. Either it's come disconnected from your patient, the whole chest tube has come out, or you have a crack or a leak in your tubing. That also means the air is going back into your patient. So this needs to be addressed immediately and fixed. The suction control chamber here, this is a traditional wet suction water seal chest tube. And so there's a hole here. Air is being sucked through there, up this way through the wall suction. That's what is controlling suction from both this chamber over here and from your actual patient. That's why the certain amount of fluid in this chamber is what actually controls the amount of suction going to your patient. You have to think about this. You have to look at this. You have to listen to me talk about it. You have to watch videos. This isn't a really simple concept for most to just understand. Nursing care. The chest tube has to stay upright. It has to stay below the level of the chest. The tubing has to be coiled so there's no dependent loops that can get filled with blood and fluid and occlude the tubing. You're going to assess the chest tube itself at insertion site, the dressing there, as well as the chest drainage system at least once a shift, if not upwards of hourly, to make sure that it's functioning appropriately. You're going to look for titling in the water seal chamber. So not only does that little tiny bit of water seal have bubbles escaping through it intermittently, which is the air escaping, it also has titling. And that means sometimes the water goes up and the water goes down. It goes along with inhalation and exhalation because at first there's a lot of pressure, negative pressure in the chest cavity. As that the lung starts to expand, then you see less and less titling up until you see no titling. And no titling is okay. That's not something you need to report. That likely you might report it to the physician just to say, hey, there's no titling. I think this patient's getting better, but you wouldn't report it as a problem. There should be no bubbling in the water sealed chamber except for intermittently as air is escaping from the chest. So intermittent bubbling in the water sealed chamber. Output report greater than 70 to 100 milliliters per hour. If it's the first hour after chest surgery, maybe there's going to be some. It should get better and better. You shouldn't see the reverse. Make sure you're collaborating with the provider for providing cares and monitoring and assessing. If you have any concerns, you should be communicating with them. No clamping the chest tube unless there's an air leak or you're removing or changing the chest drainage system. Then you will take padded clamps and you take 2 of them going in opposite directions. You do padded because you don't want to split or break the chest tube. Okay. At the bedside, then, you always want to have 2 pairs of padded clamps. You want to have sterile water and you want to have an occlusive sterile dressing or a dry dressing in occlusive tape for two reasons. The clamps are in case it comes disconnected or there's an air leak, you can clamp the tube. Or if you need to change it, you can clamp it very temporarily. This should be temporary. Sterile water is the most ideal thing to use if the chest drainage system becomes disconnected from the chest tube, because then you take the end of the chest tube that's outside of your patient and just stick it in the sterile water and you create your own water seal. The occlusive sterile dressing is most important if the whole chest tube comes out unexpectedly. Then you put an occlusive sterile dressing, petroleum coated, or a dry dressing with occlusive tape over the site to prevent air from going back into the chest until the providers can get there and address the patient. There is some conversations in some books about, in fact, you only tape these on 3 sides. And why might you only tape them on 3 sides? Well, again, it's kind of like a tension pneumothorax. You want air to escape from that chest, but you don't want it to go in. And so taping it on 3 sides would allow some air to escape, but when they inhaled and sucked that dressing back up against the chest, it wouldn't allow air to go back into the chest. That is a little controversial though. So you would follow policy at your facility, and you either tape it on 3 sides or all 4 sides. Transporting the patient. The best thing to do to transport a patient, disconnect them from suction and leave the suction port open. If you don't leave the suction port open, air cannot escape from the chest. So you leave the suction port open on the top of the chest tube so that air can escape from the chest, yet you still have your water seal intact. So the water seal is intact and doesn't allow air to go back to the chest. These are the things that you're going to assess frequently and ongoing as when you have a patient who has a chest tube. Respiratory status, vital signs, skin assessment, capillary refill, all of these things that are telling you, do they have oxygenation? Do they have perfusion? Do they have gas exchange? You're going to palpate around the site for subcutaneous emphysema. Is air leaking underneath the skin? That's a problem. We should report that to the provider. Sometimes it happens when we put a chest tube in and we just note that it's there as long as it's not getting worse. But if it wasn't there and now all of a sudden it is there, that's a problem. Knowing we want patients to still do breathing exercises, cough and deep breathing, incentive spirometer, head of the bed up, positioning the patient frequently and ambulating are all going to help promote good respiration, good deep breaths, help get those lungs re-expanded and opened. Complications, air leak is the number one. Continuous bubbling in the water seal should not be occurring. It's a sign of an air leak. If you also have an air leak indicator on your chest drainage system, look at that. Those things will tell you there's an air leak. So what are you going to do? You're going to follow the tubing to see, is there a crack? Is there a hole? Did it become disconnected? Did it come out of my patient? And rectify the situation as soon as possible. If the whole chest tube comes out, you cover with an occlusive dressing, tape off 3 sides. Most references say 3 sides. And if the tube becomes disconnected, just so the chest tube is still in your patient, but the tube became disconnected from the chest drainage system, then you put the end of the tube in sterile water. That is best practice. Day 2 of caring for a patient with a chest tube, you walk into the room and note there's continuous bubbling in the water seal chamber. Your client is short of breath and the oxygen saturation is 90% on room air. What is your initial step? Think about that for a minute. Look at those vitals. They're day 2 of caring for the patient. So this tube was not just placed. Your client's short of breath and their oxygen saturation is down. What is your initial step? You should quickly note there should not be continuous bubbling in the water seal chamber. Therefore, this patient has an air leak. So you're going to follow the tubing and see, is it the tubing that's cracked on the chest drainage system? Okay, just clamp the tube, disconnect it, get a new one, reconnect it. Has the whole chest drainage system come apart, disconnected from the chest tube? Open your sterile water and stick the end of the chest tube in the sterile water. Now you've created your own water seal. Air can still escape from that chest, but when they breathe in, air cannot go through the water up the tube. If the whole tube has come out, you get an occlusive dressing and you put it over the patient's wound where the chest tube was and prevent air from re-entering the chest. Now the patient's on day 5. You're assessing the client and note there's clear lungs. Chest effort is easy. Respiratory rate is normal. Oxygen is great on room air. Chest tube drainage is less than 25 mLs per day. There's no bubbles or tidling in the water seal chamber. All of those are indicators that the patient's lung is re-expanded, and we should communicate with the physician about these findings, or at least document them in the chart so the physician can see them and note that likely this patient is ready for chest tube removal.